Good afternoon, everybody. Today we'll just change the topic from diabetes and all its complication to the bone and osteoporosis. Okay, what is bone? Bone is the ultimate biomaterial. It is light, strong, and can adapt to its functional demands and repair itself. So it is a very strong architecture that support and maintain our body. And if we look at the function of the bone, mechanical support, protect visceral organs, mineral homeostasis, especially calcium and phosphorus. And what's the bone structure? It is mediated by remodeling. It maintains the optimal mechanism of environment and adapt to a loading condition. Biology of the bone. The bone is made of two types of bone, trabecular or cancellous bone, or cortical or compact bone. The cancellous bone is spongy. It supports and strengthens the long shafts, and the cortical bones surround the bone out from outside and make the shaft of the long bones. So, trabecular bone, mainly seen in vertebrae and long bones, we lose it through loss of hormonal deficiency. The major site is vertebrae and foramen, and it is very vascular and compromises 20% of the total bone. What about cortical bone? It's seen in long bone, skulls. We lose it by immobilization and aging, and the major site of fractures are hip and vertebrae, and compromise 80% of our skeleton. What about the macroscopic structure of the bone? It is cortical or trabecular, as I said. The bone surface, we have endosteum and periosteum. The microscopic structure is extracellular matrix and the bone cells, osteoprogenitor, osteoblast, and so on. This is the structure of the bone from inside, microscopic. And here is a comparison between normal bone filled with compact, cortical, and calcaneous bone, and bone filled with holes. What is osteoporosis? It is bone filled with holes, characterized by decrease or an accelerated bone mass, structural deterioration of the bone tissue, and there are increased metabolic turnover of the bone. What is Wolff's law of bone formation? Bone is laid down where it is needed and reabsorbed where it is not needed. We need a minimal essential strain. That's why when we do exercise, we strengthen our bone. We don't do exercise, our bone resorbs. And this is the normal bone formation. It occurs throughout our life, since childhood till death. There is osteoclast, remodeling, removing the bone, then osteoblasts come into pictures, form a newer bone, then the lining cells. Definition of osteoporosis: it is a porous bone. It is characterized by low bone mass, microarchitecture deterioration of the bone tissue, and increased fragility fracture. Bone turnover, either because of reduction of bone formation or resorption of the bone. Resorption of the bone increase at menopause, loss of sex hormone or corticosteroid ingestion, and decrease with estrogen therapy, bisphosphonate as anti-resorptive or calcitonin. Bone formation decrease with aging, physical inactivity, and increase with exercise and anabolic steroid like teriparatide. So, when we talk about the bone, we have to talk about calcium homeostasis. Calcium homeostasis, the powerful hormone, is the parathyroid hormone. It maintains the homeostasis of calcium. We have to look into it about calcium deprived, or when we have low calcium or calcium abundant. Whenever there is hypocalcemia, PTH will be pumped in circulation from the parathyroid gland. It will enhance the reabsorption of calcium from the gut, indirectly through activation of vitamin D, absorption of the calcium from the gut through activation of vitamin D, and reabsorption of calcium from the kidney, and bone resorption. However, when there is abundant calcium in circulation, parathyroid hormone gets secreted in a pulsatile manner. It stimulates the osteoclast to shed the old bone. Then at the end, there will be osteoblast, overactivity, and formation of new bone. So during normal calcium circumstance, normal calcium level in the blood, parathyroid hormone is the powerful hormone to maintain the homeostasis and build the bone. Bone changes with age. Up to the age of 30, there will be mild bone built. Between the age of 30 to 40, very gradual bone loss. Early menopause, there will be rapid bone loss. Then late menopause, there will be slower bone loss. And there will be age-related bone loss. Just if you look here, when I talk about bone, most of the time I talk about her disease, she disease. It is a female disease after the menopause. The main hormone which maintains the integrity of the bone in female is the estrogen. The maximum bone strength in female reach up to the age of 30. Later on, however, what she do, she will lose the bone. So almost always we advise the female to build their bone before the age of 30. What are the definition of osteoporosis? We have certain categories: normal bone, osteopenia, osteoporosis. Osteoporosis when the T-score is below minus T.5. Diagnosis of osteoporosis is made mainly by radiological, by measurement of bone density, laboratory biomarker, and to a research center's bone biopsy. The standard of care is to measure the bone mineral content and bone mineral density. The DEXA scan, the dual energy X-ray absorption measure the real bone, and sometimes we can go for CT scan, which is the actual bone. Definition of osteoporosis. Osteoporosis is defined as a T-score below minus 2.5 or more, or sometime a pathological fracture with less than 1 minus 0.25. World Health Organization osteoporosis guideline, whenever it is below minus 2.5, this is osteoporosis. Between minus 2.5 to minus 1 is osteopenia, normal minus 1 and above. Bone density scan is needed to detect the low density before fracture occur. It predicts the chances of fractures. It confirms the diagnosis of osteoporosis, distinguish between spinal osteoporosis and other spinal abnormalities. Also determine the rate of bone loss when it is timely done in a year manner. Also, effect of treatment, like when you give anti-resorptive medication, you follow those patients and see their outcome. Indication for bone density, to decide regarding long treatment, monitoring the progress of osteoporosis, long-term uses of corticosteroid, and diagnosis of primary hyperparathyroidism, and recent fracture with osteoporosis impacted, and multiple risk factors. So what are the consequences of osteoporosis? Multiple falls, broken bone, kyphosis, fracture, shortening, loss of height, and compromised viscera, especially the lung when there is restrictive pulmonary disease. Okay, fracture rate increase with the increase of the T-score, with the T-score of minus 2.5. Osteoporosis is a woman disease. 70 to 80 of those are affected are women. Why? Because of low peak bone mass, low loss of estrogen after menopause, long lifespan, and physical inactivity. Type of osteoporosis, postmenopausal female, it is 6 to 1 in male, and age-related 2 to 1, mainly vertebrae and foramen in postmenopausal, loss of ovarian hormone, and increased bone resorption. Age-related, it's lack of vitamin D, decreased exercise, and will be decrease in bone formation. What about bone loss after menopause? They could be fast loser or slower. However, we can prevent it by exercise, diet, and calcium supplement. A primary risk factor for osteoporosis, age, especially after the age of 60, female gender, low peak adult bone, races like Caucasian, Asian, and slight body build. Estrogen depletion at early in life, family history, and lack of exercise. Other risk factors: cigarette smoking, underweight, excessive use of alcohol, excessive fiber consumption, excessive caffeine consumption, and inadequate lifetime intake of calcium and vitamin D, and possibility dietary factors. Those are other risk factors, medication and diseases. Most of the chronic illnesses lead to osteoporosis, like chronic renal disease, chronic diarrhea, hyperparathyroidism, and so on. Prevention. How can we prevent osteoporosis? Modified risk factor, physical activity, physical exercise, adequate calcium intake, adequate vitamin D supplement. Always we advise our patient to take calcium and vitamin D and do exercise to build their bone. Prevention of osteoporosis, calcium and vitamin D, weight-bearing exercise, strengthening the muscles and the bone, healthy lifestyle, early treatment of secondary causes like primary hyperparathyroidism and its treatment, early prevention of steroid use, like any patient on steroid, especially in like bronchial asthma or steroid-dependent bronchial asthma, when they are on steroid more than 5 milligrams of prednisolone, they have to be in calcium and vitamin D supplement to prevent the osteoporosis. BMD testing and medication when appropriate. You have to be familiar with sources of calcium all the time. We can show pictures to our patient. These diets can have a calcium supplement for you. Type of calcium, there are many types of calcium. Calcium carbonate has the highest level of calcium saturation. However, calcium citrate is highly absorbable and lesser side effects. Treatment of osteoporosis goals, mainly prevent fractures, stabilize or achieve or an increase in bone mass, relieve symptoms of and fractures of skeletal deformity, maximize physical function. Okay, what's the indication for pharmacological treatment for osteoporosis? If the T-score is less than -2.5, or those with osteopenia with a FRASC score of after 10 years more than 20%, or a fracture of the hip more than 3%. This is a FRASC scale. You put the data. When you get the score like of osteoporosis fracture major more than 20%, those patients is needed to have pharmacological treatment for osteoporosis. Effect of FDA-approved drugs on bone. I just listed all the medication available for treatment of osteoporosis with their reduction of spinal fracture or hip fracture, because most of the time we look at spine and hip fracture because those are deteriorous. If we have spinal fracture, the mortality rate more than 30% in less than 1 month. So, FDA-approved therapeutic option, prevention estrogen in between the anti-resorptive medication and treatment like teriparatide and denosumab. Okay, anti-resorptive and anabolic therapies. Anti-resorptive decrease bone resorption. Most treatment agent, example bisphosphonate, selective estrogen receptor modulator, calcitonin, estrogen, and denosumab. Anabolic like anabolic steroid or synthetic teriparatide. Management of osteoporosis. Estrogen, retrospective analysis and some retrospective study demonstrated increase in BMD. However, estrogen nowadays not used because of World Women Health Initiation, because there was increase of breast cancer by 26%, increase in heart attack, 41% increase in stroke. So what we have alternative for estrogen, we have the SERM, selective estrogen receptor modulator. It binds to estrogen receptors, produce an estrogen agonist effect in some tissue, and produce an estrogen antagonist effect in others. Raloxifene given is 60 milligram once daily. What is its skeletal effect? Decrease the biochemical marker by 30%. On 3-year therapy, the BMD increased 2 to 3% at the hip, and decreased the incidence of vertebral fracture by 30 to 50%. It has an extraskeletal effect, reduction of invasive breast cancer. Raloxifene adverse effect, hot flushes, 2 to 3-fold increase in the risk of venous thrombo events. Calcitonin, nowadays we don't use it because of tachyphylaxis and short duration of action. It has decreased biochemical marker by 20%, small effect on the bone, 1 to 2% in the bone density, reduction by 36% in women with pre-existing vertebral fracture. Side effect, nasal stuffiness and possible increase in cancer. What about bisphosphonate? The mainstay of therapy, like treatment therapy for osteoporosis, is exercise, diet, calcium supplement, and bisphosphonate. Bisphosphonate like alendronate, risindronate, epandronic acid, and zoledronic acid. Treatment of osteoporosis is used for prevention of postmenopausal osteoporosis, prevention and treatment of glucocorticoid or induced osteoporosis, and treatment of men with low bone density. Bisphosphonate effect. They increase the bone density in spine by 5 to 8% at the hip and 3 to 6% in 3 years therapy with bisphosphonate. There was a reduction in the vertebral fracture by 40 to 70%. Alendronate, risindronate, and zoledronic acid showed significant reduction in vertebral fractures and in osteoporosis and hip fracture in women with osteoporosis, epandronate has lower effects. Bisphosphonate contraindicated in hypocalcemia, creatinine clearance below 30. Oral dosing requires certain maneuver like standing, not sitting, an empty stomach. Sometimes we have to adhere to this and explain to our patients. Bisphosphonate side effect, it is class warning like regarding GI symptoms, influenza-like, or class warning regarding jaw osteocalcinosis. Osteonecrosis of the jaw. On prolonged use of bisphosphonate, with any procedure, dental procedure, we have to advise our patient that they are prone for osteonecrosis of their jaw, so we have to be cautious. Also, atypical fractures of the femur in patient taking for long-term agent like denosumab or bisphosphonate. Sometimes we have to have a holiday. We have a safety margin of bisphosphonate for over 10 years, even denosumab. However, we have to have a window of stopping the medication for 1 to 2 years and follow the biomarker. FDA safety and update. Be aware of the possibility of atypical fracture. Evaluate the patient who is present with new groin for atypical hip fracture. Discontinue potent anti-resorptive medication in patients with atypical fracture. Okay, long-term therapy. Stopping treatment in high-risk patient. After 5 years of alendronate, decline in BMD, rise in biochemical marker, no increase in fracture. Those medications, even if you stop them for 1 or 2 years, still they have a protective mechanism regarding the prevention of fracture. Bisphosphonate holiday in patient at high risk for fracture, continue treatment, relatively safe up to 2 years. Then after that, we have to stop for 1 to 2 years. Low risk patient, we can give them a drug holiday for 1 to 2 years after 5 years. Denosumab is also a novel medication. It is monoclonal antibody given 60 milligram subcutaneously every 6 months. It is anti-resorptive medication. It increased the 9% increase in spinal BMD after 3 years in FREEDOM trials. There is significant reduction in the new vertebral fracture by 68%, 40% decrease in hip fracture, and 20% decrease in non-vertebral fractures. We have a safety margin in using denosumab for more than 8 years. This is the mechanism of denosumab. It binds to rank, it suppresses the osteoclast activity and causes more bone formation. Bone density decrease or drop when we stop denosumab. That's why we advise our patient to continue denosumab in a timely manner. So, take-home message for denosumab must be administered in timely and continuous fashion. No medication holiday with denosumab should be there. Denosumab adverse effect. It could be serious infection, dermatitis, pancreatitis, so we have to be cautious. But relatively, it is a safe medication, and we use it for a long period of time. Synthetic teriparatide is anabolic synthetic parathyroid hormone. It is a powerful hormone. It is given in a pulsatile manner of 20 microgram. It is the only treatment or the only anabolic bone-forming treatment for osteoporosis. It is given only for 2 years. Beyond that, we don't have data, and there is increased chances of osteosarcoma. BMD does not fully predict the reduction in fractures risk. Anti-resorptive treatment decreases fracture risk more rapidly and more efficiently, even if you don't see any minimal change in BMD. Like sometime, if BMD of a patient of minus 2.5, you initiated anti-resorptive medication, and after a year, still it is minus 2.5. It is a success of therapy, and it has a beyond the change in BMD. It prevents the risk of fracture in those patients. Treatment summary. It is safe and effective therapies and available. Anti-resorptive agent prevent bone loss and preserve architecture, improve quality of bone, reduction the risk of fracture in all agents. Alendronate, trozendronate, zoledronic acid, and denosumab proved to reduce the risk of non-vertebral and hip fractures. Anabolic agent, synthetic paratide, increase bone density and size, improve quality of bone, reduce the risk of vertebral and non-vertebral fractures, and no hip fracture data is there. Thank you.